All right. Good evening, everyone. I hope everybody's well. We're going to get started here in a little bit. We still have some people coming into the room. Let's do this. Everybody go ahead and chat in for me if you don't mind. Chat in if when you're planning on taking the exam. Get our fingers working a little bit tonight. All right. We got some more people coming in. We're going to give it just another minute and we'll get started because I know you got a lot to do. All right, we got some people kind of, yeah, we got folks taking it all different times, which is great. And we got some taking it in April, not too far away. Got some taking it in July. We got a good spread here. Nice. I'm sorry. Oh, we had somebody with their mic on. Excuse me. All right, we are going to let me do one more. We'll get started here. Okay. All right, folks, let's do this. Let's go ahead and just go with that first question here. So, get moving. So, thanks for coming online. Thanks for doing this. Therapy Ed really believes in trying to do as many things as we can as a company and to help students. And so hopefully this is helpful for you. And we'll have a chance to go through some different questions. Tonight, we're going to talk about differential diagnosis, kind of primary care. So we'll hit on some of those other systems and talk about kind of get a good chance to do some differential diagnosis as well as some examination skills today. Um, again, I feel like one of the most fortunate people to ever walk the face of the planet. I was active duty military PT, physical therapist, was a graduate of the Army Baylor program, and got a chance to really do a lot of differential diagnosis. Still do in my clinical practice. I do nerve conduction EMG studies in a really busy neurosurgery clinic, pain clinic, PT clinic, kind of interdisciplinary clinic, and see a lot of different patients who come in with really diverse symptoms, to include some of the things that we're going to talk about today. And then also practice, like I said, as a military PT, and then I get a chance to teach at the University of Incarnate Word here in San Antonio. Also do some things at some different programs, to include where I was at as a student and where I was a faculty member at Army Baylor for a long time. So very fortunate. And we're going to ask. Let me get a couple more people coming in here that we want to let in. And then let's do this. So let's get started here a little bit. So we're going to talk about differential diagnosis today, examination, kind of those referral pain patterns. We'll hit on some different systems. Just, big picture as you get ready to take this question. Everybody actually chat in for me too. Have you taken, I'm curious, how many of you have had a chance to take a practice exam at this point? I know a lot of you are taking it in April. I'm sure you've taken some practice exams. And when you do that, you quickly realize you kind of study by system, right? You study by, often when you're studying, you'll study musculoskeletal one day, or maybe for a 3 or 4 week, or excuse me, 3 or 4 day, 5 day period. And then you kind of hit those exams and you do a 5 hour exam, and it requires a lot of mental agility because the first question is a Parkinson's question. The second question is about wound care. The third question is about abdominal aortic aneurysm, and it just moves right, left and right. And so those of you who are getting ready to take that exam in April, you're getting practice tests in, and we really recommend try to make sure, if you can, try to get 3 to 4 practice tests in. You want to, before you do that final test, get in 3 or 4 practice tests because it gives you a lot of repetition and it gets you used to getting that mental agility you need to do well on this exam. Your exam's different. Those of you in 2024, you are taking an exam that is 225 questions. If you took this exam at last year, 23, you'd be taking 250 questions. So the good news is you have less questions. The difference is you have some video-based questions, you'll have some scenario-based questions. But again, this is, I think, a benefit to everybody. People that have talked and again, having the scenario-based questions where you have kind of 3 questions that are laid out on a case study is really to the test exam, to your benefit, because a lot of you have learned and you're in the clinic and you're seeing patients. And so being able to have all the data and answer 3 questions from it is to your benefit. So do not be intimidated by those questions, all right? So I just should throw this up here. This is just right out of the FSBPT content. So the Federation State Board PT content. And this just kind of shows across examination, differential diagnosis, how many questions you're going to have in those different categories. And we are going to spend a lot of time tonight talking about some of these other systems. But I share this from a perspective of when you think about differential diagnosis, a lot of the primary care PT, differential diagnosis, other systems that we're going to talk about here that I'm highlighting right now, really you have to have a really solid foundation in the big three of musculoskeletal, cardio, pulm, and neuro to know what are the typical symptoms that a patient would have for those kind of symptoms or those kind of systems, and then be able to compare and contrast given a history and say, well, that doesn't fit a typical musculoskeletal pattern. That doesn't fit a typical neuromuscular pattern. That doesn't fit normal. That fits cardiopulm pathology, and maybe there's something going on in the heart. Maybe it isn't, neck pain, jaw pain, arm pain. We're going to get a chance to answer some of these right coming up right here. So on the different breakdown, just I highlight when it comes to examination, and we'll hit on this tonight, like I'm just using GI as one example. This is right out of the content outline, but this is where the exam ties in a lot of anatomy. You have to know anatomy, basic physiology, and then what are the examination items that stress those tissues, right? And that could be everything from palpation, and that could be everything from a cervical quadrant test or Sperling's test, just doing some type of a movement-based test or a palpation-based test to reproduce. When we're talking about differential diagnosis, a lot of what we're going to talk about tonight, when we're talking about referral pain patterns, those are specific areas where we're going into the quadrant, right? And trying to reproduce symptoms and pain. So these are special tests, again, that you want to be familiar with as far as examination questions that would come from these smaller systems. All right, differential diagnosis, prognosis. I always highlight this prognosis piece because remember, these questions aren't just about are you able to get the right diagnosis, but also given a diagnosis and given some signs and symptoms, what would the patient look like 3 months from now? How aggressive could you be in treatment or not be in treatment based on that? So being really thoughtful about, don't just think about it from a diagnostic perspective. Also think about these kind of questions are going to ask me about prognosis. They're going to ask me, as I've highlighted here, about how can you manage the patient? So would I refer the patient? Would I not refer the patient? If I did refer the patient, what other tests would be helpful from an imaging perspective or a lab perspective or a surgical procedure, potentially even, right? So those are all fair game questions that could be asked as part of this category of differential diagnosis, prognosis. That includes patient management even from a non-pharmacology perspective, medical management perspective, as well as also what would be the impact on different medications for patients. All right. I also highlight this one, regenerative medicine. This is a new area that was brought up just in this content outline. So you could get asked a question about how would you manage a patient who's had plasma-rich protein injection for a tendinopathy or for knee osteoarthritis. So those are things that you want to just, again, take a look at. What would be different about this patient who's had plasma-rich protein injection or stem cells, and how would that be different? How would the rehab be different for that patient? And then systems interaction. This is a unique category. This is a category of where patients often will have more than one condition, or they'll have a condition that impacts the whole body. So those of you who have taken practice tests, you kind of know when you read these questions, you go, yeah, this is different. It's about the impact of cancer. It's the impact of psychological conditions, different dimensions of pain, patients who have multiple conditions like diabetes, hypertension, as well as they're being referred for knee osteoarthritis. So, and we'll highlight some of these as we go through tonight. All right, so let's do some questions. All right, I'm going to give you the time here. I'll count down. I'll give you a little 30-second warning, and then we'll talk, and then we'll do this. And then let me do this. I will start the poll while you're reading this first question, and I'm starting the timer. All right, we're going to go about another 30 seconds. Okay, we got about 80% that have pulled in. Let's go about another 10 seconds here, give everybody a chance to answer this one. All right, I'm going to end the poll. I'm going to share the results. Here we go. And awesome job on this first question. And what is this kind of describing? The patient's a little bit nervous and apprehensive. First time they've been to PT, initial visit, that's not surprising. They've got some, they're a little bit of movement, a little bit of sighing, kind of getting rid of some of that nervous energy. But by all means, this can be a benefit in treatment. So they've got good energy coming in. It doesn't mean they're distracted or not focused. So the correct answer here is this patient, and what you're describing here is mild anxiety. All right. So this gets into this is a systems interaction question. So different psychological conditions, and you want to make sure as you're getting ready for the exam, go ahead and review those key things, especially when we're thinking about, anxiety, depression, bipolar, post-traumatic stress. These are all examples of different conditions. You want to feel comfortable with what are those signs, symptoms, and even in some of these conditions like depression and anxiety, mild versus moderate versus severe symptoms, because questions could also ask you about how would you manage this patient with these type of signs and symptoms from a referral perspective, and or not referring the patient. Okay, so that's one example of kind of a systems interaction question focused on that. This is again, how do we manage these patients with anxiety? This is the other kind of thought process. This patient with mild anxiety, that's energy that when you focus it as a PT can be really constructive for the patient, right? So getting them focused, getting them on a thing, getting them up, moving can be really important to help get rid of some of that anxiety. It's when we get into more moderate to severe that then we start to see the other options that we had up there, which were panic attack. That's leading towards severe anxiety leads towards panic attack, right? And really physical symptoms that really keep the patient from even doing anything. So just being able to get back through that, review back through mild, moderate, severe depression, anxiety, and those most common conditions that is laid out in the review and study guide, but also great references in the O'Sullivan physical rehab textbook for those conditions too. All right, next question, and I'll restart the poll here. All right, we're going to go about another 10 seconds. About 67% have polled in here, so keep hitting those poll answers. What do you think? All right, we're going to end and share the poll. All right, take a look at the poll, everybody. This is a great example of a question where you're able to read it, you very quickly say, this is not a musculoskeletal condition. This is not fitting with an L3 radiculopathy, and it's not fitting with hip osteoarthritis. All of you eliminated those two options. This is good test taking. Nice job. And that leaves you with, okay, that pain referral pattern, right? When we read about that pain referral pattern, that fits with something going on in the GU system, right? That's a kidney referral pattern, a ureter referral pattern. So then you say to yourself, okay, based on these signs, symptoms, and history, now I have to kind of, okay, pick the best answer. Is this more of a UTI presentation or more kidney stones? Well, kidney stones would be acute and intense, right? So people with kidney stones present really hard, fast pain, in not 4 out of 10, but 8, 9 out of 10, and it's an insidious onset, quick, fast. This patient has been over 5 days. The other thing that kind of gets you leading towards the idea that this is more of a UTI also is the fact that their appetite's depressed, they're fatigued. Older adults especially can get confused, and not just older adults, but if you get septic enough and you have a UTI where it's starting to cause fever, you can get really confused no matter how old you are. So this correct answer here is nice job. 72% of you got it is UTI. So just again, is this fit with the musculoskeletal? All of you identified that. Nope, it's kidney or it's ureter, something to do with the renal system. What fits, and then eliminating that kind of based on time frames. If you're ever given a time frame on a question, that's really helpful. That helps you get an idea often to eliminate some options. So this pain referral pattern, you can see really fits with more kidney ureter, which all of you identified, which is great. Okay, question number 3. All right, we're going to go about another 20 seconds. All right, I'm going to share the poll. All right. So looking at this question, you can kind of see at the poll, we got a little bit of a spread, right? So as we look through this, kind of think through what are some key words here. So atraumatic, so there's no trauma related with this. And this patient's having right atraumatic shoulder pain, scapular pain. It's been going on about 3 days. They do not have any consistent aggravating or easing factors, which kind of makes you think, well, that doesn't really fit with shoulder impingement, because usually they'll say certain things, especially overhead activity, is problematic. They have normal active range of motion and strength testing, again, not consistent with right shoulder impingement. So now we have to think about what would be consistent with right shoulder pain. And the thing that would be most consistent with right shoulder pain would be cholecystitis, or also that would be inflammation of your gallbladder. So number 4. All right, so 4 is the correct answer. We think about the pain referral pattern. So as we think about spleen, that's in the left upper quadrant. So that doesn't fit. That would refer to your left shoulder. So if somebody comes in and they're saying, I'm having this really diffuse, intense left shoulder pain, we think of a couple things. We can think of the heart. That's not good, right? That can happen. More consistent left side than right side with heart pain. But also the spleen can be a referral source to your shoulder on that left side. So, or anything that comes up against the diaphragm on the left side. So lung irritation also could be a source. So, or diaphragmatic irritation. So in this case, what we do see, and that's going to be highlighted here in green, is your gallbladder. And so your gallbladder, you can get pain right in that right upper quadrant where you're going to palpate into that right upper quadrant. That'll often reproduce that right shoulder pain. All right, we're going to go on to the next question. So again, other examination items. So a Murphy's sign, positive Murphy's sign, that's when you get your hands and you put them in the right upper quadrant, push in underneath. If you get right under your ribs and kind of palpate and go deep there, what you're going to feel is what? You're going to feel the margin of your liver. Underneath your liver is your gallbladder. So liver and gallbladder are going to refer to that right upper quadrant. This is a nice picture. This is out of the review and study guide. There's other places where you're going to see this, but are similar images, but kind of gives you an idea what those different organs are in different areas. All right, question number 4. Okay, another 20 seconds. All right, we got about 80% that have pulled in. All right, going to end the poll and share it. This is not an easy question, I will tell you right now. So I'll share the results. So this is not an easy question because it really forces you to kind of walk through some different scenarios. So again, let's kind of talk through this. So you've got an individual who has this right hip pain and they've been walking. They went out and did a lot of weight bearing, 5K, walk for charity, and they're having this significant 8 out of 10 pain. They go to the emergency room or they go somewhere, they get x-rayed because they're having this tenderness in their right anterior hip after weight bearing, and they've got a femoral neck stress fracture. Now you can ask yourself, 5K walk, most people that shouldn't induce that type of a reaction to the bone, which tells you there's something going on with the bone. Bone health is not good. So which of these conditions would be most consistent with problems with bone health? So number one, rhabdomyolysis, that is when you have overexertion. What can happen is you can have significant breakdown in muscle tissue, which then can overload your kidneys. And so you get actually acute renal failure. That acute renal failure can be really toxic to your kidneys and can cause a lot of different problems. So those are patients who, when you have rhabdomyolysis, I saw this a lot in the military where people would get into basic training, they weren't in real great shape, and they would do thousands of push-ups a day. And over a couple of days, they could develop rhabdomyolysis because they're just breaking down so much muscle. That's even in healthy people, this can happen. So especially if they're dehydrated. So rhabdomyolysis, you think of acute muscle pain, intense pain. It's not localized to one place. It is throughout wherever that muscle group is working. And it can cause, because you're breaking down so much muscle tissue, it causes a lot of creatine kinase, which goes in and gets filtered where through your kidneys. So you get worried that not only is it a muscle problem and pain, but it can also cause acute renal failure. What number two, kidney stone, right? That kidney stone would not necessarily, it may produce, we just talked earlier about, what the pain referral pattern of the kidneys, but what it wouldn't do is it wouldn't diminish your bone health, nor would rhabdomyolysis. Acute renal disease from rhabdomyolysis is not when you get decreased bone health, that happens over time of the kidneys being chronically a problem. And the correct answer here is number 3. So chronic renal disease. So as you're studying your GI, GU conditions, you also want to think about what are those signs and symptoms that go along with those. And those are really well laid out in the pathology textbook by Goodman. And then testicular cancer, this one, again, it does not, testicular cancer can, but it's not one of the primary cancers that metastasizes to bone. It can, but it does not nearly as much as breast or lung or thyroid or those that are primary prostate that go into bone. So if this would have been a question about prostate cancer, I'd be more concerned about, metastasis into the bone, less likely in testicular cancer. We also see testicular cancer in what patients, typically younger males. Yeah. So this is a kind of a summary slide. This is out of the review and study guide, but also different textbooks. But when you study your diseases, think about what are those complications, those secondary conditions that can go with it that may impact the patient. The other thing that's really common with chronic kidney disease is peripheral neuropathy. It's the second or third, depending on which resource you read, second or third leading cause of neuropathy behind diabetes and alcohol abuse. So yeah, real common that patients will have peripheral neuropathy if they've had chronic renal disease, especially if they've been on dialysis for a long period of time. All right, not an easy question, but a good one to go through because it really helps you think through a lot of different types of conditions that may be related and can happen after those secondary conditions after kidney disease. Okay, I'm going to restart the poll. We're going to go to number 5. All right, we're going to go about another 10 seconds. We got about 80% that have polled in. All right, I'm going to share the poll. Here we go. So this is I mean, these are all real patients that I've had and worked with. And this individual, I'm going to give you some more history. This individual came in to see me. He was a infantry officer. He was came in and said, I'm basically here because I'm having my knees are bothering me a lot. And I'm having a hard time running and keeping up. And he was a company commander. He's somebody who was in charge of a lot of people. And so he was used to running about 6-minute miles. And now over the last 2 years, his 2-mile time had gone down to, he was really struggling to keep that up. And matter of fact, now he was even as you read through this, so this is somebody who's got decreased motion in multiple joints, right? And so if you put rheumatoid arthritis on this as your answer, I would not, I thought that's what this patient had, because he said to me, and he basically came in with a referral for knee pain. And I asked him, I said, hey, talk to me about your other, and I gave him a medical screening form, body chart, and he filled out basically his knees. And he also said, oh, I got a little bit of pain in my toes. And then when I started to ask him about, well, any other joints? Well, yeah, my fingers are a little stiff. Yeah, sometimes and then when he said his jaw, I was like, interesting, like, right? So I thought for sure he's probably got some active arthritic condition, rheumatoid arthritis, ankylosing spondylitis, something's going on that's an active arthritic condition. And then, but then he started talking about this fatigue and weakness. And he said, and I said, weakness. And he goes, yeah, literally, I'll get to the point when I'm running where I now over the last about 3 months where, I really I have to go to a walk and my feet work well, my calf muscles work well, but I feel like my quads just don't have anything left. My glutes don't have anything left. Like hard for me to if I was if we try to do like calisthenics after we run, I can't, like squatting can't, it's almost impossible. And for a young 35-year-old person who's been fit most of their life, you're like, this just doesn't seem right. And then the other thing he shared was, I said, well, or I said, and I looked at his hands and his fingers were just huge. And when I say big, his knuckles, his knuckles and his PIPs were just, really large. And I said, do you feel like you've seen bony growth in other places? And he says, oh, I don't know, maybe. He says, it is weird. I've had to change my ring size 3 or 4 times, or 3 times in the last couple of years. I said, what? He said, yeah, my rings have, I said, because they're too big, or because they're too small? He said, yeah. So then I started asking questions about, like, okay, well, do you have, what else is going on? Like, have you any other medical signs, symptoms or things that you've had to do consistently? He says, well, I have noticed my vision has been off a little bit. So where I'm headed with this individual actually had hyperpituitarism and archimeglia. And what was happening is, and when he started talking about vision, and I tested his vision, he was losing peripheral vision. And when you lose, right, we're going to get into neuro now. Bitemporal hemianopsia, when you lose those temporal fields, right, you lose your peripheral vision. That happens usually two primary things. One is, well, it's at the optic chiasm. That's what causes that. And it can be often common in MS. You can demyelinate at the optic chiasm. You lose peripheral vision. The other thing that causes that is a pituitary adenoma. So if you have your pituitary gland has a tumor and it grows, it will sit, where does it sit at? It sits right underneath your optic chiasm. So when it gets bigger, it pushes into your optic chiasm. Patients will lose vision, they'll get headaches. But that tumor that's growing is an actively growing pituitary, meaning you're secreting more hormones out of the pituitary gland, which then causes you to have more growth hormone, more cortisol, more all your adrenal gland hormones, and you get really diverse signs and symptoms. And so what he was describing here is not just joint problems, and his joints were basically fusing off because of the growth hormone. He was literally and he had said, like, yeah, my feet are bigger. Like, I had to change my shoes. So as I started to ask about his fingers, then all of a sudden he was like, well, yeah, my shoes, I said, 35-year-old male does not, your feet don't get bigger. That shouldn't happen. Right. So he had archimeglia, and he had hyperpituitarism. So he had a lot of different hormone things. He was referred, and ended up getting that pituitary adenoma taken out. And his symptoms got better with endocrine management for sure. But again, these are the signs and symptoms. You say that's a really diverse case. It is a really diverse case. But where I'm headed with this is, really important that you study in endocrine. That's going to fall into these kind of differential diagnosis conditions. You guys understand diabetes really well. You understand hyper and hypothyroidism really well. It's some of these other conditions. Make sure you go back and look at Cushing's disease, Cushing's syndromes, Addison's disease, Addison syndrome, compare and contrast. This is a summary table out of the review and study guide. You don't have to have this, but when you look at these different endocrine conditions, you want to compare against those different conditions to really feel comfortable with not only what the signs and symptoms are and what the risk factors are, but also what are the PT implications for management. So again, because you're going to get asked intervention questions about these different conditions. How would you treat a patient with hyperthyroidism? And mainly, what are you most concerned about? So that these PT implications are really helpful, and specifically special, as like certain conditions go along with certain things. So this is a nice compare and contrast here, when you look over that. All right. Okay, last question, and then we'll have time here to also, if you guys have questions. All right, we're going to go about another, let's go another, this is a lot, it's got a lot of information in it. This is almost more of a scenario-based question. You could ask 2 or 3 questions from this, like the scenario-based questions that you could get. So we're going to go another 20 seconds or so. We got about 40% of people who have pulled in. So please, yeah, we're going to take a little bit more time. All right, we got 75% of people pulled in. Let's go another 10 seconds. All right, I'm going to end the poll, share the poll. Here we go. Another tough question. Again, and so don't feel bad if you didn't get where we're going with this, because this is all about review and kind of identifying. So this patient, a lot of different types of neurological signs and symptoms, and I promise this will come back to differential diagnosis here in different systems. But so this patient has significant right arm pain, and it's kind of all the way down, right? It goes down the right arm. What's unique, kind of interesting, is it's going down the medial forearm, the medial, or excuse me, medial arm, medial forearm, and the hand, and the pinky, and the index finger. Okay, so that, think about this from a dermatome perspective, that crosses T1, right? So we're going T2, actually T2, T1, and a little bit of C8. So from a dermatome, this is definitely multiple dermatomes is what it appears to be, right? This also appears to be, when you think about the muscle testing, you got 3 out of 5 in the right first dorsal interosseous, flexor carpi ulnaris, abductor pollicis brevis is weak, and then all finger and thumb extension is weak. So you've got you've got C8 muscles, T1 muscles across 3 different nerves, median, radial, and ulnar, all weak. Whenever you see that scenario, median, ulnar, radial, that's either multiple nerve roots, or that's trunk, or that's cord, one of those, right? And more than likely, it's going to be anywhere from trunk to cord, depending on what that's going to happen, especially the fact that the patient's not necessarily having a lot of neck pain. Now, it doesn't always have to have neck pain with radiculopathy, and you guys have seen that in the clinic. But where I'm headed with this is just to say this patient, you can kind of rule out ulnar neuropathy at the elbow. And you guys did a good job of that. Most of you were able to go, okay, yeah, there's more than just one nerve. So I can get rid of kind of this ulnar neuropathy. Because of this C8 thing, you've got multiple, right? We're crossing multiple dermatomes. So there's some clear T1 involvement in here because you got first dorsal interossei, which has some C8, but has a lot of T1 or a lot of T1. Flexor carpi ulnaris has T1. Abductor pollicis brevis has some T1. So there's some C8 and T1. So you can cross out two. So this is more than just one nerve root. That leaves us with lower trunk brachial plexopathy, also called the inferior trunk brachial plexopathy, or a posterior cord. Now, the posterior cord comes out of the C7 nerve root, so that doesn't really fit with this patient. So you can cross out 4. Posterior cord would be more C7 type muscles that also get feed in from 6, also get for a little bit from 8, but don't really have a lot of T1. So as much T1. So less, and again, I can show you when we look at the plexus why this is a lower trunk brachial plexopathy. All right, that's the correct answer. Now, this is, again, not an easy question. So let's look at this. So if you do the lower trunk, if there's something pressing up in this area on the lower trunk, it's going to involve both C8 and T1. And right, what it's going to do is it's going to, all these things. So medial pectoral, so your pecs are going to be weak. Your medial brachiocutaneous, anti-brachiocutaneous. So all those are going to, that sensory distribution is going to be problematic. You're also going to have what? Ulnar involvement, radial involvement, medial involvement of C8T1 muscles. You're going to have a posterior division, which comes up into the posterior cord. That means your thoracodorsal, well, that's your lats, could have a little bit because they have some C8. So you can see that this is going to have some pretty diverse signs and symptoms. Where am I headed with this? So this is not your typical presentation because what do you get worried about up against that? So let's walk through this a little bit. I'm going to ask you, let's chat in. So what proximal C8 T1 muscle could you also test that would probably also be weak? Because I told you all these hand muscles and forearm muscles, but what would be a muscle, a more proximal muscle that has a lot of C8 in it that you could test? Anybody want to take a guess? Good. Pec minor. Yeah, right. Pec minor, pec major is going to be weak because that's got C8 in it. So this would be a patient where if you had them lift their shoulder off the table and looked at pec minor or you looked at the pec major, that's got C8 in it. That's going to be problematic. And if we go back to this plexus, right, medial pectoral nerve is going to be involved in this lower trunk type problem. So I always look at the pec. If somebody has this really kind of unique distribution down their arm, if I go up in the pec is weak, I'm like, yeah, this is really proximal. We got something going on. What do anybody want to make a guess? What's the cause of this lower trunk or inferior trunk? What's pushing up against the inferior trunk, do you think, in this patient? What if I told you they were a smoker? There we go. Nice job. Yes, Pancoast tumor. So that right upper lobe of your lung it can get if it gets a tumor, that's called a Pancoast tumor, and that can sit right up into that inferior trunk, or depending on where it's at, can also go into the cord, but either cord or trunk, and it can cause this exactly the signs and symptoms that I was talking about. Now, the other thing to think about with this question and kind of keep in context too is if I see patients that have pain, look at this, radiating pain down the inside of the arm. Look at that, into the finger. So I had a patient literally a month ago who's referred to me who came into our clinic and came in to get a nerve connection EMG because they were having neck pain with radiating pain down their arm. And they were older. They had cervical stenosis. They had radiographic findings, MRI findings of nerve root compression in their lower cervical spine, upper thoracic spine. So it anatomically, from an MRI perspective, made sense. But when I started to ask them and look through their history, and have them move, I couldn't really reproduce the symptoms. Like I could reproduce the neck pain, but I couldn't reproduce the sensation down the arm until I really through any of my things. They also had a complete normal neuroscreen. They didn't have any weakness, no sensory problems from both from sharp dull testing as well as from monofilament testing. And so as I went back to this and I was asking them, what aggravates, they said, just, I don't know, nothing consistent, nothing consistent. And so, what I went back and thought about as I went through again, as I was doing their physical exam before I even did the nerve conduction, I said, I'm curious, do you ever have problems with this when you're like exerting? And they said, well, yeah, I mean, like if I'm walking for a period of time, a long period of time, I kind of do notice it go down my arm more. And so I went next door, talked to a colleague, and this individual's vitals were not, he was 135 over 80. So they weren't drastic, but he was having some early congestive heart failure with exertion, and he was getting referral pain from his heart. So he was not a surgical candidate. So if you look here, right, when we look down at this referral pattern, if you're seeing people with this kind of a distribution, I'm not, if it's neurogenic and there's weakness and numbness, well, that's probably means there's either a root problem, a cord problem, or a trunk problem or a plexus problem, right? But if it's here, especially if it's bilateral with shoulder, what the patients will say is my both shoulders hurt or I'm having chest pain, shoulder pain, you want to think heart referral. Yeah, as part of that. All right. Folks, and so this is an example. This is a picture of a Pancoast tumor. Check out this image here. So this looks really obvious when you look at it on a CT scan, right? And look at how lobular that tumor is and how that grows up in above the clavicle, right at the clavicle and above. And then here, it's not, you have to kind of get yourself in the sense of what this looks like. And, again, on this plain film, it's just hard to see, but is this outline up here, right? And so this outline up in here is what you're seeing as, unfortunately, tumor that's pushing up into the plexus. So Pancoast tumor, bad situation, and you want to recognize it. Most common in smokers, most common, again, in people who have had a long history of smoking with lung cancer. So if you ever have anybody who comes in with a history of any type of cancer or lung cancer, this is something you want to think about. Could be a problem too. So, all right, nice job, everyone. So again, really, really good. Let me stop sharing this poll. I'm going to put that down, and I am going to stick around if there's any questions, and I will answer any questions that you guys have. Also, just give me a quick, if you don't mind, turn those cameras on and wave goodbye. Thank you for being part of this tonight. Also, I just want to share there will be another one next week. So we have if you go onto the website for Therapy Ed, you'll be able to see the upcoming ones, and then this one will also be put on YouTube. So if you have any interest at all, this presentation will be, you share it with your friends. This will be up on YouTube probably within the next couple of days. Thanks for coming online. You got that exam. Crush it. Take care. Thank you. Thank you so much. Appreciate it. Thank you. Have a great night.